psychiatrists, MD psychiatrists, they make about $3.50 an hour. So if you're looking for a job that pays really well and has very little overhead, like, I don't know if any of you guys have ever seen a psychiatrist, but like, you don't really have a staff or anything like that. It's just like, you know, they're in like a building with a bunch of other people, and they get a little office, and you go in and you know, talk to them, and they prescribe you meds.
A lot of them are telehealth too. Still.
Most of them are telehealth now, yeah. So telehealth is really kind of the way of the future for psychiatry and mental health. So
why is your pay so high?
why is pay so high for psychiatry? Because it can be.
Yeah.
$3.50 an hour.
That's kind of, you're just prescribing medication.
Sure, yeah, but it's because it's highly specialized. So,
Right.
yeah, it's like
It's a lot of schooling.
yeah, it's like putting in flippers. Like why do they charge so much for flippers? Because they can.
The material's expensive.
Yeah. So
Yeah.
it's like radiology, right? It's really yeah. So there's a huge demand for psychiatry. People don't want to go into psychiatry. So
Why not?
Because it's a lot of school.
well, well, even within the medical profession, it's there's in the 1970s there was a movie called One Flew Over the Cuckoo's Nest. Has anybody seen One Flew Over the Cuckoo's
I've heard of
Nest?
it.
It stars Danny DeVito, Jack Nicholson, and so Jack Nicholson is a guy who gets locked up in a mental institution, even though he's not actually crazy, and kind of can't get out of there once he's in there. And it's a really like somewhat accurate at the time, but really like horrific depiction of what mental health services were like, especially mental hospitals. And so like when people think of like psychotherapy, when they think of psychiatry, right, usually we think of like emergency psychiatric medicine, right? So literally, people in straitjackets and actively suicidal and like psychotic and all of that, which you can do that, right? You can be an emergency psychiatrist, work in like hospitals, mental institutions, things like that. And like that's kind of like the ER version of psychiatry, right? But does anybody here know somebody who sees a psychiatrist, friend, family, relative, right? So most people that go to see a psychiatrist, they've got depression, or they've got they're bipolar and they just need medication to help, or they got bad anxiety or whatever, and they just need somebody to help manage things. So, but a lot of people think of psychiatry as just like everybody in straitjackets and everybody's psychotic and all that. So,
Are there any clinical demands for that? Like when you're going to school for it, do you have to do a certain amount of hours?
Yes, you
in
do,
that type of environment specifically?
Yeah. So like any type of medical, like when she goes to dental school and whatever type of medical he goes for. So when she goes to dental school, she's going to do rotations. She's going to do general dentistry. She's going to do orthodontics. She's going to do endodontics, right? All of that kind of stuff like that. Yeah, all of that. You get exposed to all of that. Same thing for, so in med school, right? So the first 2 years of med school is all like this, right? It's all like laboratory and lecture stuff. The second 2 years is the fun stuff. You actually do rotations, right? So you'll do like all of the branches of medicine. So
is that when you declare your specialty or figure out like?
Well, that's how you figure out what you want to do, right? So you do like a 6-week rotation of obstetrics, a 6-week rotation of enterology, a 6-week of radiology, all of that. So that's what you do the second 2 years of med school. Then you do your residency, and then in your residency, like you'll be exposed to all of the different types of like subspecialties within your particular So like if you want to be a psychiatrist, right, you're going to do rounds at like various different types of places. But especially when you're a resident, like you're going to do all the like dirty work that the other people don't want to do. Yeah. So whether that's all ER or whatever, yeah. So yeah, you're going to do all the dirty work that none of the other doctors want to do anymore, including psychiatry.
No, they've earned it.
So
not have to do it anymore.
Yeah. So, but the ones that like the emergency psychiatry, that's the thing, right? That's not my thing. Like I don't like working with so it's what we call SMI, severely mentally ill. Like I don't want to deal with the severely mentally ill. But some people that really like doing that. Some people don't like doing what we call retail psychiatry. So somebody that just needs they got anxiety and they need an anxiety medication. So, but that's the vast majority of what psychiatry is I've got depression, or I've got anxiety, or my kid's got ADD. So, or I think my kid's got ADD. So. All right, guys. Today we're going to talk about the respiratory system. And every semester I get a student who says, "Isn't it pronounced respiratory?" But if you actually go on Webster's Medical Dictionary, the correct pronunciation is respiratory system. Okay. When you guys think of your respiratory system, what do you guys think of?
Your lungs.
So we think of our lungs. What else?
Heart.
Huh?
Your heart.
Heart, well, that would be the cardiovascular system, and it does work hand in hand with the respiratory system. So the respiratory system does two things, okay? So it is responsible for ventilation and respiration. Okay? What's the difference between ventilation and respiration?
Is one of them air coming in and the other one is air coming out?
So ventilation is bulk flow of air, moving the air in and out of the lungs, and respiration is a gas exchange, right? So there's two types of respiration. So there's gross respiration, which happens in the lungs, and then there is cellular respiration. Remember learning about cellular respiration in some general biology course. So what's cellular respiration?
Like oxidative respiration?
Oxidative, yeah, so gas exchange, right? So the actual gas exchange, right? The vast majority of what your system is doing is that ventilation, right? We're getting the air into the body through various different passageways and using creating negative pressure, and then only in the alveoli of the lungs is where we actually have the gas exchange actually happening, meaning oxygen is exchanged with the capillaries, and then CO2 is also exchanged. So oxygen goes into the capillaries, CO2 comes out of the capillaries, and then we exhale, right? So we inhale, bulk flow of air goes in, right? It goes all the way down to the bottom of our lungs to our alveoli. Oxygen diffuses out, carbon dioxide diffuses in, and then we ventilate it back out, okay? So ventilation and respiration are the two main functions of the system. So we could call it the ventilatory system, but for some reason we call it the respiratory system. So that's really saying right there, okay? Now, our respiratory system can be divided into two subsections, the upper and the lower. The dividing line is where the glotted opening is. So basically, the upper tract has a common pathway with the digestive system. So for example, the back of our mouth, right? That's both the digestive as well as the respiratory system. And then we get to the larynx here. We have a thing called the glotted opening. That's the opening to your voice box. There's a flap that covers that called the epiglottis, which we're going to talk about here in a second. The epiglottis is what prevents you from getting food or liquid going down to your trachea, right? We've all had that happen before, right? You're drinking or eating something and you cough or laugh or something else like that, and water goes down the wrong, or liquid goes down the wrong tube, right? You cough it up very, very quickly. Okay? So for example, one of the things that can happen when people have a stroke or other type of TBI is they have dysfunction with their swallow reflex. So one of the things you might go see a speech pathologist, commonly known as a speech therapist, for is to relearn how to have a proper swallow reflex. So that's one of the common things that, so speech therapists do a lot more than just help people with stutters and things like that. So the upper respiratory tract is from the larynx up, and then the lower is from the larynx down, right? So once you get to the lower respiratory tract, it's only a pathway for air, not food in it. So here are some of the pathways here. Okay, so we have, for example, we have got the nasal cavity. You may remember from the beginning of the semester when we talked about the skeletal system. Am I moving around too much for you?
You're fine.
Sorry. Right, so we've got the superior, middle, and inferior nasal concha. The function of those is to turbinate air. What does it mean to turbinate air, guys? Spin and funnel it down, okay? And then we have the oral cavity, also known, so this is known as the nasopharynx. This is called the oropharynx, and then in the back here is called the laryngopharynx, okay? So air can come in through either of those pathways. It'll go down the laryngopharynx, then the epiglottis will cover the trachea, and then food will go down the esophagus if you're swallowing. Right? So that's what happens when you swallow. Okay. So we got the oropharynx, nasopharynx, oropharynx, laryngopharynx, and then we have the larynx. We have the trachea, Then we have our bronchi. So we've got primary bronchi, secondary bronchi, tertiary bronchi, and then finally terminal bronchi. And at the end of the terminal bronchi are these alveoli. They look like tiny little grapes, right? So this gives us significant amounts of square of surface area. Each lung has about 75 square meters of surface area, which is enough to, if you were to fold it out paper thin, that each lung could cover basically this room. You remember how many square feet, how many square meters your apartment in Japan was?
We use a different, measurements, like based off rise.
Yeah, they do different weird measurements than others. So like a good sized apartment would be 250 square meters. Good sized apartment. So we've got the nose, right? So the external nose is cartilaginous. So we have what are called the external nares. So that's the actual openings to your nose. Those are called the nares. And then you've got the nasal septum, nasal concha, and then you've got hair and you've got mucus in there. The main function of the hair and the mucus is to do what?
Prevent infection.
Prevent particulate things from getting into the other parts of the respiratory system, which are more sensitive, like your lungs and all of that. Okay. This is why, for example, when you get sick, one of the common things that happens is what? What happens to the nasal cavity?
You get congested.
It's all congested with phlegm and mucus and inflammation and all of that kind of stuff like that. Okay. Then we have the paranasal sinuses. We've talked about this before. So we've got the maxillary, frontal, ethmoidal, and sphenoid sinuses. They're lined with mucous membranes, help moisturize, humidify the air, and then they serve as a resonance chamber, which affects the quality of the voice. What does this mean here?
Like vibration.
Huh?
Vibration.
Who here has heard an audio or video recording of themselves and said, I don't sound like that? And everyone's like, yeah, that's exactly how you sound. Why do you sound differently to yourself than when you hear an audio recording of yourself? Right, so when you're listening to your self-talk, you're hearing it through the resonance chambers of your own skull. So that's why your voice sounds different to you than when you hear an audio recording of your voice, right? So that's the science of it, right? What happens when when you got your sinuses are all clogged up? What happens to your voice? It sounds like right. It's all weird sounding. Right, that's what's going on there. Right, so it affects your resonance chambers. Pharynx is the last part of the common passageway for food and air. Aids in producing sounds for speech. Does anybody here know somebody that's got classical training in singing? Classically trained singer. Right? So people that are classically trained in singing, right? They learn how to manipulate their pharynx and their larynx to make, right? So that's where you like a sharp and a flat, in a particular tone. Right? So that's why you see opera singers doing those weird things with their throat and their mouth. Also to help sing longer and all of that as well too. So you got the larynx, right? So the larynx is the opening where we find the vocal cords. We have two sets of vocal cords. So we've got the true vocal cords, and then we have the false vocal cords. We call them the true vocal cords because those are the cords that we actually utilize to actually make sound. I'll show you a video of it during lab. But there is it's called Tibetan throat singing. Anybody here heard of Tibetan throat singing? I'll play you a video of it. They actually, with great amount of time and training, learn how to utilize both sets of vocal cords at the same time to sing. I'll play audio over it. It's really, really weird sounding, but they do that a lot.
How do we have the false ones? What was the point of having the second set?
Something we evolved it for some reason, so we don't know what it is. So it's probably something that our earlier primate ancestors utilized for whatever reason. I don't know, or hooting or howling, or I don't know. Chimpanzees do when they get all excited, or monkeys and gorillas do. So who knows? So, why do we have an appendix? So we've got muscles and cartilage and all of that. So you see here, this is the thyroid cartilage. That's here on the front. We've We've got the hyoid bone. We talked about the hyoid bone before. The hyoid bone is the only bone in the body that is not attached to another bone. It's just attached to ligaments and tendons. We got the epiglottic cartilage in the back. That's what actually is the flap that goes down. And then we've got it's called so right here, this is called the corniculate cartilage. Right here, this is called the cricoid cartilage. Question for you, why do gentlemen have Adam's apples and women do not? Since you all have the same stuff here. So why do men have Adam's apples and women do not? That's why we call them Adam's apples.
It's a body fat thing.
Not a body fat thing. It won't go away if you get lean.
I imagine it's testosterone driven. but-
Testosterone, right?
Yeah.
So what is testosterone, right? If you have like a kid choir, right? How much of an octave range is there in a kid's choir? Maybe 1 octave at best, right? If you have an adult choir, what's the octave range?
8.
Probably 4 to 5 octaves at least, right? So you're gonna have all the way from like alto down to bass, right? Who are typically the bass in a choir, that's an adult choir? The men who are typically the altos. You know what I mean by alto? High pitch versus low pitch? Who are the high pitch usually?
I was really hoping you were gonna say.
The ladies, right? So this is the main reason why we see pitched voices between men and women. Women's voices typically tend to be an octave or 2 higher after puberty. Men's voices tend to be an octave or 2 lower after puberty. So the testosterone thickens the cartilage and also thickens the vocal cord. So that's why men have got Adam's apples. So what would happen to a woman who either through natural means produced large amounts of testosterone or exogenously introduced testosterone in their body? What would start to happen to their structures here?
Grow an Adam's apple.
They would start to grow an Adam's apple, and they'd start to get. I told you guys about the East German women's, right? Right. So like throughout the '72 Olympics, like women kept like diving in the lockers and changing rooms, thinking men had come in because the women's East German team. They took so many steroids, they started to develop deep masculine voices. So that's what causes those Adam's apples. Okay? So again, we got the 2 sets of vocal cords, right? So the upper pair is called the false vocal cords. The lower pair is called the true vocal cords. We can change tension to change pitch and tone. So most people typically have about a 2 octave range. Some really well-trained singers can have a 3 octave change. Who here knows who Freddie Mercury was? So lead singer of Queen. So Freddie Mercury was famous for having a 4 octave range. So Freddie Mercury can do a 4 octave change. A lot of classically trained like opera singers can do a 3 or 4 octave change as well too. So we got the glottis, which is the slit, right? That's the opening. We can also manipulate that to change pitch and tone a little bit as well too. And then the glottis again, epiglottis is that the cartilaginous flap that covers it to make sure that food and liquid don't go down your trachea. This is the actual opening, right? So it's a triangular kind of a slit, right? And then you find the vocal cords right there. Then we got the trachea. So the trachea has got 20 incomplete cartilaginous rings. We watched a crash course video about that. What's the function of the cartilaginous rings? Why does the hose on your vacuum have the same kind of like ring structure on it?
Structure with flexibility.
Yeah, from collapsing when you're creating a vacuum. Right? Otherwise, every time you take a deep breath in, your trachea would collapse. Okay. So it's only partially complete because the trachea basically butts up against the esophagus in the back.
Is that when they do like a tracheotomy, they gotta make sure they palpate the right spot and get between?
Yep, that's exactly what they do. Trachea goes all the way down, right? So right about the sternal notch is kind of where the trachea, so basically this is the end of the trachea, and then you start to, that's why we typically do the tracheotomy, kind of right there. I was thinking about one of the Saw movies, a guy gets stuck in a thing, he's got a bowl on his head, he stabs himself in the neck with a pen. I'm like, I don't know if I could do that. So, although I don't know if I could do any of the stuff in Saw, so yeah.
I imagine you do a lot of weird stuff when your survival kicks in.
Yeah, I always crack me up, like, people talk about, like, what they would do in, like, these, like, really, like, terrible situations. I'm like, I'm really glad I've never had to, like, figure out what I do if, like, there's terrorists on a plane, or, I'm chained to something and I might have to saw my leg off, so. Alright, so anyway, so right about here, the trachea branches into what are called the primary bronchi, which will lead to each of the lungs. The left and right primary bronchi will then further divide into bronchioles. So we've got the primary bronchi, the bronchioles, secondary bronchioles, tertiary bronchioles, and then finally down to the terminal bronchioles. On the ends of the terminal bronchioles is where you will find the alveoli. That's where the actual gas exchange happens, okay? So your alveoli, again, they kind of look like little grapes. They are one cell layer thick, and they are surrounded by capillaries, creating what's called an AC membrane, alveolar capillary membrane. How many cell layers thick are capillaries, if you guys remember from our cardiogram? One layer thick. So since they're both one layer thick, what does this allow for to happen? Diffusion to happen, okay? So we take a breath in, we inhale, oxygen-rich air rushes in, goes down our esophagus, or goes down our trachea, goes down our bronchioles, gets to the terminal bronchioles to the alveoli. What's going to have a higher concentration of oxygen, the alveoli or the capillaries? Alveoli. So due to concentration gradients, oxygen is going to diffuse out of the alveoli and then the capillaries. Capillaries are going to have a higher concentration of carbon dioxide. So carbon dioxide is going to diffuse from the capillaries into the alveoli. We then exhale, right, and we breathe out. We breathe in gas that is mostly oxygen, and then we breathe out gas that's still mostly oxygen but has a significantly higher amount of carbon dioxide. True or false? Is it more oxygen or carbon dioxide when you exhale?
Carbon.
Which one is it? More oxygen or carbon dioxide?
Carbon.
More oxygen. Right? Otherwise, mouth-to-mouth resuscitation would be pointless, right? So at rest, right, doing normal ventilation like you guys are doing, normal respiration, you're taking in about 80% oxygen, and then you're breathing out about 60% oxygen. You don't really need a whole lot of oxygen when you're at rest. So capillaries around them, right? So we end up with really easy diffusion happening there. You got two lungs, right? They're soft and spongy, very flexible. Your one lung has got 3 lobes. Your right lung has got 3 lobes, and your left lung has got 2 lobes. Why does your left lung only have 2 lobes?
Heart.
Has to accommodate for the heart, right? Despite the fact that your right lung and your left lung aren't exactly the same size, they have equal amounts of ability to ventilate and respirate. You have the diaphragm, right, and the thoracic cage. So the diaphragm is the primary muscle involved in ventilation. Okay. And then you've got 2 membranes. You've got a visceral pleura and a parietal pleura. In between the 2, you have what's called a pleural cavity. And you have a fluid in between the 2 called serous fluid, which helps reduce the friction.
I hate that word. I hate that word.
Serous?
Yeah. Every time I read it, I just want to say serious.
Yeah. So you'll see sometimes in movies where people have like a collapsed lung, right? They've got a puncture wound. So what's happening there is you're now introducing an air pocket between the visceral pleura and the parietal pleura. So the visceral pleura is the more deep layer, the parietal pleura is the superficial layer. So what happens is, because they've got an air pocket now, every time they breathe in, what does the lung do? Right? Or every time you exhale, what happens? The lung collapses. So when it collapses, you create an air pocket, and the air pocket gets bigger and bigger and bigger, and it makes it increasingly difficult for the lung to reinflate. Right? So that's why they put the tube in the chest, and you see the fluid coming out. That's actually one of the few things they actually get right in like medical depictions in movies and TV
Is that
shows.
considered was it like thoracentesis or whatever? Is that considered thoracentesis or whatever it is? Is that
Considered a what?
I think it's called thoracentesis or something.
You mean a pneumothorax?
Maybe that, I don't know.
Yeah, that's what a pneumothorax
There's like
is.
where they pull the fluid out.
Yep, that's a pneumothorax. Yeah. Okay, So here you can see, so here is like a depiction of like you've got like an MRI or a CT scan. So the lungs are primarily posterior in aspect, which is why when you go to the doctor and the doctor wants to listen to your lungs, what do? They put the stethoscope on your back so they can get a good thing of what's going on with your lungs. Anybody a fan of like Norse mythology or like Viking lore and Viking stuff? Yeah, so the blood eagle, right? So supposedly, right, they would actually like take victims and they would actually cut the ribs in the back and then split the ribs open from the back and take the lungs and put them out like it's called blood eagle. So we don't know if that was something they actually did or if it's just like one of the like smear tactics of the people that didn't like the Vikings. So there's no evidence that it actually happened, but it's often depicted like in the Vikings TV show. It's also depicted in there. Blood eagle. All right. Let's talk about inspiration and expiration, okay? All right, so physics time. In physics, there are a couple of laws that have to do with ventilation and respiration. The first one is called Boyle's Law. Can anybody tell me Boyle's Law? So Boyle's Law states that there is an inverse relationship between volume and pressure. What does it mean to be an inverse relationship, boys and girls?
Volume goes up, pressure goes down.
Volume goes up and pressure goes down, right? So this is, for example, what happens with a syringe, right? You take a syringe, right? How many people grind their turkey for Thanksgiving? Right? So you take the syringe, what do? Stick it in the solution of brine, and then what do? You draw back the plunger. When you draw back the plunger, what are you doing? You're increasing the volume inside of the syringe. As you increase the volume, what happens? You're now creating a decrease in pressure known as a vacuum, right? So same thing happens with our lungs, okay? Atmospheric force pressure is the force that moves air into the lungs. When pressure on the inside of the lungs decreases, higher pressure air flows from the outside, okay? So we take a deep breath in. What happens? Okay, so we've got our diaphragm, right? Our diaphragm pulls down on the lungs. What else happens? What does our chest cavity do? Chest cavity expands out. Diaphragm pulls the lungs down. What does that do? Increases volume, thus decreasing pressure as demonstrated here. So watch the balloon. Okay? Your lungs work the exact same way. Okay? So your diaphragm, it's here at the bottom of your lungs. So everybody take a deep breath in. All right, so what's going on there, right? Chest cavity is expanding, lung or diaphragm is pulling down on the lungs, increasing the volume. Now what's happening to the pressure inside of your lungs compared to atmospheric pressure? Pressure inside of the lungs is lower than atmospheric pressure. What do we know about gradients? Things spontaneously want to go from areas of high to low. Pressure's higher outside of the lungs, so what happens? Air rushes into the lungs. We then relax our diaphragm, relax our chest cavity. What happens? We decrease the volume inside of our lung cavity. Thus now the pressure inside of the lungs is now higher than atmospheric pressure, and then we breathe out. Okay? So Boyle's Law is what's dictating breathing in and out. We also have surface tension, right? So the walls, the pleura of our lungs is actually mechanically attached to our lung walls. And then to help keep them from sticking to each other, we have this thing called surfactant. Okay? So your lungs are actually physically attached to the inside of your chest wall. So when you inhale, chest cavity expands, it actually pulls the lungs apart, thus also helping to increase the amount of volume so that we get volume under pressure. So Sunday morning, I flew home from Colorado Springs, and the flight attendants did their pre-flight safety talk, right? And they said in the unexpected event of a change in cabin pressure, I love that they always say unexpected, like when was they planning on this happening? Who's heard this speech before, right? Unexpected change in cabin pressure, what do they say will happen? Mass will drop from the ceiling. If you have a child or somebody that you have to take care of, what do they tell you to do?
Put your own mask
Put
on.
yours on first, and then put the other person's on. When they say that, they mean it, and they are not kidding, okay? Commercial airline, how high up are they flying? 30, 40, right? If you're maybe flying transatlantic or transpacific, you might get as much as 50,000 feet up in the air, right? What happens, anything above about 30,000 feet in elevation, what happens to the air pressure at 30,000 feet? It's so low that it's now lower than the lowest pressure you could actually generate in your lungs, right? So if you're at like 35,000 feet, no matter how deeply you inhale, you would not be able to create enough of a pressure gradient to actually get air into your lungs. Matter of fact, at about 35,000 or 40,000 feet, what would start to happen? Air is going to literally get sucked out of your body because the pressure gradient is going to be so great. The higher you go, the worse it would get. So, right, you're in a commercial airliner and it's 40,000 feet up in the air, and there's a drop in cabin pressure. You got a couple of seconds to put that mask on. All right, so if you're trying to fumble and trying to put it on your 5-year-old, both of you are just going to pass out and probably suffocate before they can drop down in time. So, how high is the highest point on Earth? First off, what is the highest point on Earth? Mount Everest. So Mount Everest is about 29,000 feet, right? Only a handful of people, a couple of dozen people, have successfully summited Mount Everest without the aid of oxygen. Right? And the vast majority of the people who have actually summited Mount Everest without the aid of oxygen have been the Sherpas. Who are Sherpas, guys? The people indigenous to the Himalayas, right? And they have special, right, over thousands of years of evolution, they've become specially evolved and suited to live at very high altitudes. So when I was, what's the altitude here? About 1,600 feet here. So, you know, we're actually one of the higher metropolitan areas in the United States. Denver's the highest at a mile high. We're pretty high up there, so is Atlanta. Think about where most people live. Most people live at or near
Sea level.
sea level, right? So, right, most people live at or near sea level. Most of the major metropolitan areas in the United States are at or near sea level. Some of them are even below, like for example, New Orleans is actually below sea level. Anybody here been to El Centro, California? El Centro, California is like about 150 feet below sea level, right? Denver, about 5,000 feet up, it's the mile-high city. Anybody been to Flagstaff? Right? Flagstaff's about 7,000 feet up. Colorado Springs, Colorado is also about 7,000 feet up. Up in, if you go to Alpine, anybody been to Alpine, Arizona? Alpine, Arizona is about 10,000 feet up, right? A lot of the Sherpas in their villages up in the Himalayas, a lot of them are, and same thing with the Incas down in the Andes in Peru, a lot of those villages are 13, 14, 15,000 feet up in elevation. And they've been there for millennia, right? So they've developed special abilities to be up there, right? All right, so expiration, right? So expiration is mostly due to elastic recoil, right? So simply all we do is right, to inhale, we contract our diaphragm, pulls down on the lungs, right? When we want to exhale, we just simply relax the diaphragm, right, and it recoils back. Okay? Now, if we want to do forced expiration, like so, for example, you're trying to blow up a balloon, right? Then you start utilizing like your abdominal walls. We also have muscles here in our ribs called the internal and external intercostals that also are involved into if you really want to like breathe out really, really, really hard. So, like Trey does every time he gets in his car and starts to all right, let's talk a little bit about tidal volumes. Okay, so if you were like a respiratory therapist, anybody thinking about becoming a respiratory therapist? Good program over at Gateway Community College. We can actually measure lung volumes. Okay, so we've got a couple different types of lung volumes. We've got tidal volume. Tidal volume is a normal breath in, normal breath out, like what you guys are doing right now. That's going to be approximately half a liter. Okay. We then have IRV and ERV. So IRV is going to take biggest breath in you can, and then just let it out normally. That's going to be about that's gonna be about 3,000 liters, or about 3 liters. ERV is gonna be about 1,500 liters. And then we have vital capacity, which is, take the biggest breath in you can, biggest breath out, that's gonna be about 5,500, about 5.5 liters. Okay. And then we have, that's basically, and then we have total lung capacity, which includes what's called the anatomical dead space. So even if you were to exhale, forcibly exhale, every breath with all of your might, there's still gonna be a small amount of air inside of your lungs, which is called the anatomical dead space. Anybody here gone surfing? So if you go surfing, right, when you first get a lesson, right, they'll tell you about what happens if you get caught in an undertow. What would they tell you to do? Don't panic, hold your breath, and what will happen to you?
Float.
You'll pop up, and you'll eventually pop up. And that's a big part is because of that anatomic dead space. That's why a lot of times drowning victims, eventually pop up, like Jack after Rose kicking off the door. Okay, control of breathing. Okay, control of breathing happens in 2 areas. So we've got both the pontine respiratory center and then the medullary respiratory center. So the pontine regulates rhythm, and the medullary regulates depth, right? So how much you forcefully ventilate and respirate. They are primarily driven by chemosensitivity. So what is chemosensitivity, guys? Responding to what?
Chemicals.
Chemicals, right? Namely, specifically, oxygen and oxygen, all of that. We'll get it, we'll talk about this here in a second, okay? So, we're gonna hold our breath here for a second, okay? So, we're gonna try and hold our breath for about 30 seconds, okay? Everybody ready?
Yeah.
And go. And go. What was the first thing you guys did? Inhale or exhale? Exhale. Why do we exhale? Right. So your inflation or your ventilation or respiratory reflex is primarily driven by your need to get carbon dioxide out, not to get oxygen in. Okay. So we primarily breathe because carbon dioxide starts to build up, meaning our blood starts to become too acidic. Okay. So we breathe primarily to get rid of carbon dioxide, not because we need to get oxygen in. That's why when you hold your breath, the first thing you do is exhale out, not inhale. So, if you, so for example, right, you got somebody that's having a panic attack. What do? You hand them a paper bag, right? What happens if you don't give them that paper bag?
Oops, hyperventilating.
Why did people pass out when they hyperventilate?
Too much oxygen or not getting enough oxygen?
They don't have enough carbon dioxide.
You don't have enough carbon dioxide, okay? So I'm gonna show you guys something here. Yeah, I should get out this. Okay. So we've got, you might remember this from biochemistry. Ring a bell at all from biochemistry?
Polycarbonate
Yeah.
buffer system.
Buffer system, okay? So, you're babysitting your 5-year-old nephew, and he wants candy, and you won't give him candy. So he's gonna hold his breath until he dies, and then you'll be sad because he's dead, and it's all your fault because you didn't give him candy because he held his breath. So you call his bluff, and go ahead, hold your breath, right? And he's actually stubborn enough to hold his breath long enough. What's gonna happen to him?
He's gonna pass out, but his body will return to natural breathing.
During the breathing, right? Why is his body going to pass? Why is he going to pass out?
The low
Because
CO2.
carbon dioxide is gonna start to build up
Oh,
in his bloodstream, leading to carbonic acid, leading to bicarbonate ion, right? So his pH will start to drop. If it drops enough, right, what'll happen? He'll pass out, and then normal respiration will start to occur, right? On the other end of the spectrum, you got somebody panicking, right, because they didn't study for their A&P final, and realize it's Tuesday instead of Thursday, and they start hyperventilating. What happens to them if they keep hyperventilating?
Pass out.
They're going to pass out. Why are they going to pass out? Because they breathed off too much too much carbon dioxide, which means their pH is going up. Their pH goes too high. What happens to them?
Excuse me.
They pass out, right? And then normal ventilation starts happening. So why does having somebody breathe into a paper bag help when they're hyperventilating? You start to recycle the carbon dioxide, so it helps you prevent from your pH from getting too high. A good example of how interplay there is between the different organ systems. So you're a doctor or a nurse or PA, and you're at Scottsdale Osborne Hospital, right? And 45-year-old Pima Indian comes in, or Papago Indian comes in. They are 45, they're overweight, they come in, they're clammy, they're sweaty, and they're hyperventilating. What could possibly be going on with them? What's going to be our first instinct as a medical professional working with a middle-aged Native American man?
Heart.
Not a heart attack. They're probably going into metabolic ketoacidosis, right? So what happens with metabolic ketoacidosis? Too much hydrogen in the blood. So what does the body do to try and compensate for the excess amount of hydrogen ion due to the fact that they're not properly processing carbohydrates and sugars? We're going to hyperventilate, trying to blow off some of that extra CO2 to try and bring their pH back down, right? Same hospital, 2-year-old comes in, right? Same thing, clammy, sweating like I went to confession, hyperventilating, right? What do we think's going on with the baby? They got into the chewable, like aspirin or vitamins, and they are suffering from acute aspirin poisoning, right? Aspirin is acetylsalicylic acid, right? They're in acidosis. Their body's trying to compensate by hyperventilating to try and bring their pH back down, right? So that's an example of how multiple organ systems work together to try and maintain homeostasis. All right, so alveolar gas exchange, that's what actually happens inside of the alveoli, okay? So take a deep breath in, air goes in through the nasopharynx, oral pharynx, goes down the laryngopharynx, down the larynx, down that bronchi to the actual alveoli, and that's where gas exchange actually happens, okay? This is again due to those partial pressures. Okay?
Why is nasal breathing better quality than mouth breathing?
Because you've got the filtration system there, right? So less particulate will get in through your nose, yeah. So like, who remembers in PE, right, the coaches told you, like, do this because you'll breathe better? Total crap. We actually did a study on it. This actually is better for helping increase ventilation. So we actually did studies on it. Your PE coach, besides wearing god-awful shorts, was totally fine. Okay, so this is why things get tricky when you're at altitude, okay? There's not less oxygen at altitude. There's less air pressure at altitude, okay? So you're at 30,000 feet up, right? You're at the top of Mount Everest, right? What starts to happen to the partial pressure of O2 compared to the partial? So the partial pressure inside of your capillaries is fixed at about 40 millimeters of mercury, okay? The partial pressure at the top of Mount Everest for oxygen is like 42 millimeters of mercury. So we're talking a minuscule pressure variant, but just enough to get just enough oxygen in there. You can stand up there long enough to take a picture of yourself and then get down before you literally die. Right? You got about an hour at that altitude before your body will just say, forget it, right? We're shutting down. Right? Anything above about 27,000 feet, you're in what's called the death zone. From the time you hit 27,000 feet, you got about 24 hours to get below 27,000 feet before your body shuts down and you die. We call it the death zone. And this is why the pressure gradient becomes so much. Anything above about 29,000, 30,000 feet, right? The partial pressure of O2 is so low that no matter how deeply you breathe in, you're not going to get any gas exchange. And you actually get negative gas exchange. You start to suck oxygen out of your capillaries due to that partial pressure. Okay. So once you get the oxygen into the body, it's primarily transported in what's called oxyhemoglobin, or hemoglobin, and about 2% is just kind of free floating inside of our bloodstream. More oxygen is released as the blood concentration of carbon dioxide increases, as the blood becomes more acidic, and as blood temperature goes up. What is going to cause your carbon dioxide levels to increase, blood become more acidic, and temperature to go up? What would cause all three of those things to happen? Right, any type of physical exertion, right? So our body's designed that the more we exert ourselves, what do we need more of? Oxygen. What is the chemical change that through exertion due to our hemoglobin? Makes it more readily give off oxygen and more readily take up carbon dioxide. It's almost like our systems evolved to do these things. Crazy how that works. Okay. If you don't have enough oxygen, you end up with what's called hypoxia, which is bad. Okay. Now here's the downside to hemoglobin. Hemoglobin, because it has a higher affinity for carbon dioxide, and it has a really high affinity for carbon monoxide. Right? It has a high affinity for carbon dioxide, which is good because what does that allow us to do when we're exerting ourselves? Offload the oxygen and uptake the carbon dioxide in our lungs, right? What's the number one cause of death in fires? Is it being burned alive?
Smoke inhalation.
Smoke inhalation, CO2, right? So you're in a house that's burning, right? What's being emitted by the fire? A lot of carbon dioxide and especially a lot of carbon monoxide. You're in the super smoky room, right? Trying to breathe in, and what ends up happening? Your hemoglobin will preferentially take up the carbon dioxide and take up the carbon monoxide, and then you'll suffocate, right? Which is why we have carbon monoxide things inside of our humor. They're not just smoke detectors; they also detect carbon monoxide, right? So a very effective way to die is to be in a room filled with carbon monoxide, which is why still to this day one of the popular ways to kill yourself is to just go in the garage and start the car and just kind of drift off to sleep. One time in the wintertime, I was getting ready to go somewhere and it was really cold out that day. So I went outside and I turned the car on, but I forgot to open the garage door. And I walked out there, I was like I got instantly woozy sort of a thing. So, all right. Let's take a break. What's today's quiz going to be over? Digestive system. Does anybody need me to go over the digestive system with them since they weren't here Tuesday? Yeah. Okay. All right.